Alright guys, so we can finally finish up NBME 24 over here. So last time we left off, we finished up to question number 25 of the last 50, and I'm going to finish up the last 25 questions, wrap up this NBME. Now, near the end of this NBME, some of these questions did get really funky, they were weird, they were strange, they were very abnormal, not the type of stuff you would expect in STEP. So I did point them out. So we can just finish this up now. I looked at the last 25 questions. I'm done with everything now. This is ready to if you want to buy it, you can go ahead and shoot me an email and purchase anything as usual. Nothing really strange in the last 25 questions. They were pretty good, very meaningful. I actually liked the last 25 questions a lot, just like I liked block 1 of my order of exam. So let's just dive right into it, and then of course feel free to ask any questions you might have about any of the questions as I go through it. This first question here, 37-year-old man is admitted to the hospital because of gradually progressive weakness, anorexia, and weight loss over the past 6 months. His blood pressure is 74/40, and his skin is hyperpigmented. Morning serum cortisol concentration is 2. Which of the following is the most likely diagnosis? So the presentation he has with weakness, anorexia, and weight loss, and then a very low blood pressure, it's all indicative of the fact that his adrenal gland isn't working, right? Because if his adrenal gland was working, then he would make aldosterone and fix this, and he would make the cortisol he would need to manage any issues he's having, but he's unable to do all of that. His skin being hyperpigmented is indicative of the fact that his brain, his pituitary is making ACTH, which also had to use POMC, and a component of that is MSH. The MSH causes hyperpigmentation. So this is a patient with adrenal failure, and it was pretty evident that this is adrenal failure right when you dive into the question. You should be able to catch that pretty straightforward. So right after they talk about Cushing, the next topic is adrenal insufficiency. It's page 334. Let me put that in. And adrenal insufficiency, I copied over my notes from here. So there's a lot you need to know, right? So I break it down in my book, How to Understand Adrenal Insufficiency. I discuss the main things you would see in summary and why you would see them. And then, of course, they have a test here that's very similar to what they do for Cushing. So here you have the meteropone stimulation test, right? And you want to make sure you truly understand how that works too. Very important topic. Not worth not understanding, so you should have total knowledge of it. Let me just see something real quick. Okay. So the meteropone stimulation test, when you give somebody meteropone, it's going to stop the conversion of 11-deoxycortisol into cortisol, so you're not going to make cortisol. And then depending on what happens when you give this person meteropone, you can figure out what kind of problem they have, all right? Our patient in this question, if we give them meteropone, they would have a further increase in ACTH, all right? But we wouldn't really need to do that because they already did the AM cortisol test and it was low, right? So AM cortisol was low. Then they would check the random ACTH for the same patient in our question. They would see ACTH is high, which is already evident from their hyperpigmentation, right? So maybe he has Addison disease or an acute failure. They put Waterhouse-Friderichsen syndrome here too, but you should understand that this is a very rapid thing and it would be really problematic. So this is not Waterhouse-Friderichsen. It would also require fever, usually due to Neisseria gonorrhea. Excuse me. So this is irrelevant to all of that in that respect. Now, always make sure you understand this stuff too, right? So you're going to get questions about both adrenal failure, and then, of course, this part right here, the hyperaldosteronism, which presents in a different manner with metabolic alkalosis, right? And here with hyperaldosteronism, there's a big part of it relating to aldosterone escape mechanism, which keeps the sodium levels pretty normal. So there's a lot of physiology in that part of endocrine that often gets tested, and you want to make sure you have a good understanding of it. Other than that, all the other answer choices are really easy to cancel out because they were really irrelevant to the presentation this patient has, okay? So it just didn't make sense to pick any of them. And if you were unable to cancel out any of these answer choices, you want to make sure you go back and check them out. Make sure you know what each one of these is about. Once you know what these things are about, you'll know why it didn't make sense for the patient we have in this question. Alright, number 27. So the book gave these two images that are in the middle. Not the book. The question gave these X-rays that are in the middle. I put this one here for reference purposes. The one over here on the far left is a normal individual. So the question said a 34-year-old woman is brought to the emergency department 45 minutes after she slipped on an icy sidewalk and landed on her outstretched right hand. Examination of the right upper extremity shows an exquisitely tender swollen wrist with a palpable hard mass located immediately proximal to the wrist joint anteriorly. X-rays of the right wrist are shown. Which of the following bones is the most likely dislocated in this patient? Now, if you haven't recently reviewed this, then you might not catch it immediately. There was a reason they gave the lateral view as well, and it was for you to catch what's happening. So in the normal one, they're all labeled ABCD, which I've labeled out for you right here, so you know what each one is. And if you look at the one they gave over here, you should immediately be able to catch the fact that the lunate over here is missing. Right? There's supposed to be 3 down here, as you can see, D, E, F, which is for scaphoid, lunate, and pisiform. Right? But we can't really see it per se, right? The lunate. So then when you look at the lateral one, you can see that the lunate has kind of shifted behind what would be the capitate, right? It's behind this C. So that's what they were showing you here. I would say these are pretty good X-rays. As long as you remember what the normal looks like, right, it would do a perfect job. On top of that, if you remember the mnemonics, so long to pinky, here comes the thumb. Right, so long to pinky, here comes the thumb is a really way of memorizing it. So long to pinky, here comes the thumb. Right, and it goes in order. So this is going to be the trapezium is the one by the thumb. The pisiform or pinky is by the pinky. It's right above the ulnar part. Right, so very easy to figure out what's happening if you could just remember that mnemonic. And if you were to run that mnemonic for this guy, right, knowing that this is the pinky, so you would say so long, and the long isn't there. To pinky, here comes the thumb, and that's the thumb. Right, so the lunate, that was it. This question wasn't so bad at all. In the book, they mentioned right here in musculoskeletal in the wrist region, they talk about scaphoid being the most commonly fractured from an outstretched hand fall, right? And that would happen like this. So you fall on an outstretched hand. And then the other thing is your lunate dislocation can lead to acute carpal tunnel syndrome, right? And then the only one they don't talk about here is the hook of hamate. That can cause Guillain Canal syndrome, mostly in bikers due to ulnar trapping. So there's all of that. Alright, so nothing crazy, not a bad X-ray at all, very well done. This one was also a very straightforward question, straight from the book, so it was really just whether or not you remember it. Hox genes play a role in embryogenesis through which of the following processes? Alright, so that's straight up embryology. You do want to make sure you know those neuroembryology genes, all 4 of these, very well. So the Hox genes, the book tells you itself, codes for transcription factors, right? And then you would have to remember, what do transcription factors really do? And this is not supposed to be B, excuse me. Let me just check that real quick. Pretty sure I meant to write C. This is regulation of transcription. Yeah, I don't know why I put B here. So yeah, regulation of transcription, and that's what your transcription factors are responsible for, right? So really straightforward question. They put regulation of translation here too. A couple people fell for that. One of the students I was reviewing this with yesterday fell for that too. So you want to make sure you understand that regulation of translation is really done by things like microRNA, anything else that would inhibit translation per se, but not transcription factors, right? So, no, so the Hox genes are actually homeobox genes. The sonic hedgehog gene is its own thing. The sonic hedgehog is a separate gene that works on figuring out the zonal polarizing activity, which you can see in this image right here, right? And it's for patterning along the anteroposterior, right? So I always remember that as Sonic runs back and forth and loses his head, right? Running back and forth anteroposterior. The reason he loses his head is because if there's a mutation, if he makes a mistake in running and he trips, if there's a mutation, you get holoprosencephaly. That's a very nice. WNT7 is dorsal ventral, right? So that's another way to remember the dorsal ventral aspect that this gene sets up for you. FGF is really related to a bunch of things, but overall lengthening of the limbs. So when this isn't working, you get achondroplasia. And so all 4 of these are pretty high yield, very easily testable. You can get a lot of straightforward questions or even slightly confusing questions. Alright, so 28, that was 28, 29. 35-year-old woman with a long-standing history of asthma treated with corticosteroids dies of complications of histoplasmosis. Examination at autopsy shows that the lungs are 1.5 times the normal weight. Extensive focal areas of fibrosis and 2 to 5 millimeter nodules, 2 to 5 millimeter nodules are seen throughout both lungs. Examination of a biopsy specimen of the nodules is most likely to show which of the following findings. So long-standing history of asthma, right? Uses corticosteroids. Autopsy. So she dies because of the histoplasmosis. They're doing an autopsy of the lung, right? And then they find all this fibrosis and stuff, and they just want to know what you would find in that, right? In the nodules. So this is just going to be D, infiltration of lymphocytes and monocytes. That's it. The patient is immunocompromised and has severe histoplasma-induced pneumonia. All the systemic mycoses can form granuloma just like TB does, so D makes the most sense. Granulomas are made of lymphocytes and monocytes. Mycoses are not fought with neutrophils, which are for bacteria, or immune complexes, which is also generally for bacteria. Right? So it just doesn't make sense for any of that to be a thing. So Lena's asking my thoughts on doing the old NBMEs they released for free. First of all, I found it really pitiful that they released the old NBMEs for free. Literally, those older NBMEs, most of them, especially 13 and 15, are already all over the internet for free as it is. So they really made it look like they were doing a favor, but they didn't. I also don't find those NBMEs. I've brushed through some of them. I've gone through 13. I've looked at some questions of 15 while reviewing them with students. I found those NBMEs to be even more far-fetched as opposed to what step 1 is like now. So I don't know how beneficial it would be to do them. I think there's better things to do in terms of step 1 prep, like just finishing UWorld and AMBOSS and then reviewing UWorld, reviewing the wrongs on AMBOSS, stuff like that, and then of course going through your annotated first aid. So doing those NBMEs might actually end up not really being very beneficial because some of the questions on NBME can be so far-fetched and stupid that it's actually a waste of time to put any brain cells onto it. So I think that 13 and 15 are pretty useless. 17 I haven't looked at, nor have I looked at 19. I've done the explanations for NBME 18. I skipped over 19 and just did 20 all the way to 24 now, and I don't think I'll be doing any more NBME explanations. I feel like these are pretty good and sufficient enough for now. But yeah, I wouldn't recommend wasting too much time on doing older NBMEs. Those free NBMEs they released was pretty pathetic, to be honest. Alright, so this was just a question to remind you that those systemic mycoses do have granulomas, and that's lymphocytes and monocytes. And on top of that, it's a bit of an immunology question also, right? Because you get to see what your immunology understanding is of things, and there's no reason for histoplasma to have an increase in eosinophils, immune complexes of any kind, or neutrophils. Eosinophilia is also something you really see later on with like parasites or something, not exactly with histo. Number 30, a 2-year-old boy is brought to the emergency department because of a 12-hour history of headache, loss of appetite, and vomiting. His temperature is very high, pulse is 120 per minute, respirations are 40 per minute, and blood pressure is low. Physical exam shows nuchal rigidity. A lumbar puncture is done. Cerebrospinal fluid analysis shows an increased protein concentration, decreased glucose concentration, abundant neutrophils, and gram-positive diplococci. So when you do a CSF analysis and glucose is low, it's usually due to a bacterial infection because the bacteria are eating the glucose. That's how you can think of that. If protein is really high and glucose is normal, then you have a viral infection, an aseptic CSF infection without bacteria. The protein count goes up because of the virus, either it's DNA or RNA. So here the protein count, they're saying the protein concentration is increased, and that can be for many reasons, but the decreased glucose definitely means there's a bacterial issue. And then they also found the gram-positive diplococci, which pretty much confirms strep pneumo. Immunization with which of the following would most likely have prevented this patient's infection? So this is a straight-up immunization question. Immunization for strep pneumo, It's a very high-yield topic. S-pneumo vaccination is extensively discussed in my microbiology videos. I talk about it regarding the PCV13 and the PPSV23. The PCV13 is given to younger kids. It's attached to diphtheria protein to elicit a memory B cell development as well as T cell and IgG. So it's very immunogenic, very useful in kids. In adults, you give a PPSV23, which is mainly going to form IgM because it's not very immunogenic. But as an adult, you won't need an immunogenic thing because you've probably already had the immunogenic aspect of things. Right? So that's the big part about that. Alright, Vigneshwaran, I wish you luck, man. Good luck with that. One more week to your test. Yeah, don't fry your brains out looking at too many things now. Just relax, review whatever basics you need to, and just make sure you are ready for whatever you have to wear. There's a lot of protocol changes. You can't really leave the prometric room. You can't leave the building. You have to have a face mask on. You can't really go to your locker. There's a bunch of different kinds of changes like that. So make sure you look at the prometric website to know that stuff. COVID tests. Alright, here, this was a pretty cool question. 62-year-old man comes to the physician because of a 2-month history of intermittent severe pain of his left leg that began shortly after the leg was amputated below the knee. Pain is described as throbbing, aching, and shooting and is localized to the distal portion of the absent extremity. Each episode lasts from several seconds to a few minutes. The pain is exacerbated by feelings of anxiety and changes in temperature and is not relieved by changing position. His vital signs are within normal limits. Examination of the lower extremity shows a well-healed surgical scar over the stump, so that's perfectly fine. Neurologic exam, including muscle strength, testing, range of motion, deep tendon reflexes, and muscle tone, all of it is normal. Which of the following is the most likely cause of his symptoms? And you see the answer to his phantom limb pain. Remember I was saying that after you've looked at enough NBMEs, you get the idea that whatever that strange answer choice is, that unknown, rarely seen answer choice is, oftentimes that is the correct answer. And here it was. This is phantom limb pain. This guy had an amputation below the knee, and this is a very common thing. So I'm glad they asked the question about it. At least it's not something very far-fetched. It's very likely you might actually encounter this in your practice one day. Phantom limb pain occurs because of amputations. It's almost after, like, 90% of amputations lead to that. So your body, it's like a neurological anxiety thing, which is why they actually mentioned that he has anxiety. He where do they say it? Let me see. The pain is described, blah, blah, blah. Seconds, pain is, by feelings of anxiety and changes in temperature. Right? It's exacerbated by that. So it's all because his brain is looking at the missing limb that's been amputated, and it's not naturally eliciting pain. So when you see yourself missing a leg or something, your brain just starts sending off these pain impulses because it's painful for your brain to even understand it lost a leg, right? Very normal, natural thing. This video here actually talks about phantom limb pain in more detail, so I'll put that in the chat to make it clickable. And that's basically all that this one is about. 32, okay, so 33-year-old woman comes to the physician because of a 2-month history of easy fatigability and dark urine in the mornings. She has not had fever or weight loss during this period. She has not traveled internationally. She doesn't take medications. Her temperature is normal. Pulse is 107, which is high. Respiration is at 20, and blood pressure is normal. Physical exam shows scleral icterus. That's not normal. Hemoglobin is low, right? Hematocrit is 35. There's a problem with the bilirubin here, so you can see her total bilirubin is 3.5. Direct or conjugated is 0.2, but there's a lot of unconjugated bilirubin, right? 3.3. A lot of unconjugated bilirubin. And then her urine has blood in it. The result of a direct Coombs test is negative, and the result of an acidified serum test is positive. So that tells you a lot, because if the Coombs test is negative, that means it's not due to any kind of antibodies that are causing hemolysis or something. The acidified serum test being positive, you might have never actually heard of. Which of the following best describes the underlying cellular cause of this patient's condition? So abnormal cell morphology. Would abnormal cell morphology lead to this kind of anemia that she's having with all this indirect bilirubin? Possibly. Decreased G6PD activity. This is not G6PD related at all, so there's no reason to think of that one. Defect in the cell membrane anchor protein, so that would be like spectrin not working or something. That could cause hemolysis also. Destabilization of the cytoskeleton, and then underproduction of globin proteins. So this patient actually has paroxysmal nocturnal hemoglobinuria. There were only two things in this question that could really help you figure out the answer. One thing was, almost never does a question tell you that a patient has fatigability and dark urine in the mornings. She only has dark urination in the morning because paroxysmal nocturnal hemoglobinuria happens overnight. Right? So the hemoglobinuria formed overnight, and then when she went to urinate in the morning, there was blood in the urine. The acidified serum test is actually related to that as well. So let's take a look at this in first aid. They don't talk about the acidified serum test in first aid, mainly because it's not really a test that's done anymore. So I put the question into my first aid right here. But this is a defect in the membrane anchor protein, right? A defect in the PIGA gene preventing formation of GPI anchors for complement inhibitors, such as decay accelerating factor or the membrane inhibitor of reactive lysis. If you can't stop these things, then you end up killing your own red blood cells, right? You're going to have decreased haptoglobin because all the haptoglobin is binding the free hemoglobin, so you no longer have free haptoglobin anymore, right? And wait, I think that's a spectrum here, but the spectrum was about the abnormal cell morphology. So abnormal cell morphology will be something related to like a spectrum issue or whatever from hemonc, which would give you spherocytosis, right? Spherocytosis is another possible thing that can cause hemolysis, but it wouldn't present in this manner either. She wouldn't just have all this blood in the urine, right? That's a very important thing to watch out for. So blood in the urine really would catch off guard a lot of G6PD people, and they might pick B. G6PD deficiency does present with some of these symptoms, but no medications, no travel, doesn't eat fava beans, hasn't really had any infection, so there was no stressor to actually cause the G6PD deficiency symptoms. So a very interesting question about paroxysmal nocturnal hemoglobinuria, right? Usually when you see questions on PNH, it's going to be very obvious. So this made it a little less obvious and it introduced something new to you, an acidified serum test. All right, so acidified serum test, you got to make sure you know it. I wrote it here, positive acidified, you take the patient's red blood cells and place it in mild acid, and a positive test indicates red blood cell fragility. This is no longer done due to its low specificity and sensitivity because that can also be positive in aplastic anemia and a couple other things. So it's not a very common thing, but this question wasn't that ridiculous though. It was a pretty good question. 33. 3-month-old boy is brought to the emergency department because of shortness of breath and listlessness for 3 hours. He has had an upper respiratory tract infection and eaten poorly for the past 3 days. Temperature's fine, so he doesn't look like he has infection anymore. Oh, he doesn't look like he has infection anymore. Respiration is 30 per minute. Physical exam shows lethargy and mild hepatomegaly. Lab studies show hypoglycemia, lactic acidemia, ketonemia, and metabolic acidosis. Following the IV administration of glycerol or fructose on different days, his serum glucose concentration doesn't seem to increase. However, they do increase normally after the IV administration of galactose. Okay. A defect in which of the following liver metabolic pathways is the most likely cause of these findings? So this was an excellent question to grasp your understanding of the metabolic pathways and all the different interplays the sugar things have. So in my recent video where I talked about how to revise things, I mentioned that you need to revisit metabolism multiple times, right? One time you're going to revisit it when you're done with endocrine to revise all the sugar stuff. So that would be the glycolysis, the gluconeogenesis, the glycogenolysis right here, right? And then also anything about ketogenesis, right? Then you would come back another time when you're doing GIT to revisit urea cycle because that's related to hyperammonemia, right? Any other time you're studying one of the topics that talk about fat, you would come back to look at lipid metabolism, and then you slowly but surely start making the connections. So they tell you in the question that when they give our child glycerol, when they give this baby glycerol, they're unable to get glucose to increase. So glycerol, normally when you give someone glycerol and they don't have sugar in their body and you give them glycerol, IV glycerol, the glycerol would become DAP, become fructose 1,6-bisphosphate, go up this gluconeogenesis pathway and make free glucose, right? So for some reason that's not happening. They also mentioned they gave fructose, right? So giving fructose, again, giving fructose also does a similar thing. So if you give somebody fructose, that would start from somewhere like right here, right? Because these are all the different fructose things. and then it would go up and you would make glucose out of it. So for some reason, those things are just not working. Oh, fructose is over here, excuse me. Right, fructose is right here. So this would also go the same kind of pathway. So glycerol is right here. This would become DAP, and then you would make free glucose. Fructose is over here. This also eventually becomes DHAP, and then goes up here and makes free glucose. For some reason, both of those pathways were not working. However, when they gave the baby galactose, and I think I might have written something different in the explanation, so I'll fix that up. But when you give the baby galactose, you can see right here is galactose. So you can see it starts at, all three of these things start at a different path, but there was something shared between glycerol and fructose, and that's this port right here. With galactose, it just becomes glucose 1-phosphate, which then becomes glucose 6-phosphate, and you can make glucose. So this part is working, right? This part is working right here. This portion here was working just fine, but for some reason this area is not working. So the glycerol failed, the fructose failed, and that's what they told you. So overall, that was not so bad to work with, even if you don't have perfect memory of this page, because then is for whatever reason gluconeogenesis is not working fine, right? The baby is able to make ketones just fine, so that's great. It would be a different type of question if the question mentioned hypoketotic hypoglycemia, but that's not what's happening here. The baby is making ketones. Lactic acid is being formed, which means that pyruvate must be getting shunted. Right? Pyruvate is being shunted to become lactate because it's just not going up anymore in this direction. Not that it could really, but you're not trying to do this TCA stuff, right? You're not trying to do this TCA stuff. You could make pyruvate become acetyl-CoA and shunt it this way to make glycerol and do all this gluconeogenesis. And you have to remember that pathway too. But again, this baby for some reason is unable to do it. So all of those things are not working, and everything in the question is meaningful. But those meanings can only really be derived as long as you understand this entire page, the summary of all the pathways. So when you finish mastering biochemistry, you should be able to talk about this pathway without the pathway in front of you. You should at some point even get so good that you can actually redraw this pathway without the pathway in front of you. Right? So if you've never actually drawn this pathway, you should do it. Like sit down, draw the whole thing out, put the enzyme names in there, look at all the interconnections, label the rate limiting enzymes, label any enzymes that have kind of, or any substrate that has some kind of upregulation of major enzymes, and make sure you have a memorization of that. Because then you would have that memory. You know, just looking at it and studying it is one thing, but when you actually write it by yourself and you have to keep looking at it to keep rewriting it correctly, big practice, right? So giving galactose giving galactose was the only thing that led to glucose formation, but fructose and glycerol were unable to do it, so that's a sign that gluconeogenesis is not working, right? That was all you had to do for this question. I think something in this explanation I might have miswritten, because I don't remember writing galactose. So I'll come back and look, yeah, fructose, I kept talking about fructose by mistake. So I'll fix that up later on. But yeah, make sure you understand the whole galactose part, right? So like I pointed out in this image, make sure you come back to this image every time you see questions regarding any of these things. 34, an 83-year-old woman is brought to the physician by her daughter to discuss the results of a complete dementia workup. The patient has had mild memory impairment for 8 months. She takes no medications, vital signs are normal, mini mental state exam score is 23/30, and RPR is 1 to 4, and the microhemagglutination assay for treponema pallidum is positive. Okay, so both of this is pretty much telling us that the patient has syphilis. Which of the following is the best next step for the physician? Very interesting ethics question. So you should definitely be able to rule out D or E because there's no reason to repeat either of these tests. You don't repeat these tests. You might want to order more tests, but you don't want to repeat these tests. There's no point. RPR is the screening test. Microhemagglutination assay is actually a confirmatory test. So that hemagglutination for treponema pallidum is very specific to pallidum. So, you know, the patient definitely has syphilis. Disregarding the results since the patient is too old for treatment is never how you're supposed to think. That is an unethical form of thinking. No one is too old for treatment. If you're alive and you need treatment, you get treatment. So that leaves you with A or B. Discussion of the diagnosis with the patient privately or discussion of the diagnosis with the daughter privately. And it should ring a bell for you that there's no reason to discuss this with just the daughter privately. The patient is actually just fine. All the patient has is just mild memory impairment, but none of this is telling you that the patient is unable to have good cognitive judgment, right? Even her mini mental state exam isn't below 20. So 23 out of 30 for an 83-year-old is actually pretty good. So you don't need to worry about that too much. And you could share her private information about her diagnosis and whatever came out in her test results with her. Now, if she told you, please let my daughter be present, or I want my daughter to know, or something like that, that's her decision to make, and at that point, you can go ahead and talk to the daughter. Right? But until she says it, you would not discuss it with anyone else. The 83-year-old woman is your patient. She is your customer. You deal with just her directly. This was probably like the fifth or fourth question regarding this stuff. A 27-year-old man comes to the physician because he and his wife have not been able to conceive a child. He has poor libido and is unable to maintain an erection. He has been receiving thyroid hormone and corticosteroid replacement therapy since surgical removal of a pituitary adenoma 2 years ago. His serum testosterone is 0.05, which is very low. Right? Normal is 10 to 35, so his basically got no testosterone. Semen analysis, because of the lack of testosterone, shows azoospermia. Which of the following is the most appropriate treatment to restore this patient's fertility? Now, since he has no testosterone, we need to get him to start making testosterone. Giving him testosterone, if that was even, well, I guess that's choice E is giving him testosterone, but giving him testosterone is not the same thing. There's a difference between having testosterone throughout your body and having testosterone locally within the testes, okay? And you don't really inject testosterone into the testes either. That's not a normal thing. So that local testosterone is what actually causes sperm formation and spermatogenesis and all of that. There's a lot of testosterone binding globulin in the testes because it wants to hold the testosterone in that area. Testosterone anywhere else has different effects, right? So it's a whole different mechanism for that. Oral progesterone would be completely irrelevant. Testosterone patches would not be helpful. Injections of GnRH might actually be harmful, but more so, we know that this baby this guy, as a baby, had his, not even as a baby, sorry, 2 years ago, had his pituitary gland taken away. So with no anterior pituitary, GnRH will have no effect. So there's no reason to give GnRH. Injection of gonadotropins, that was the only thing that was left, right? So give FSH or LH or both, because then LH can go to Leydig, right? And then cause the Leydig cells to make more testosterone, and it would fix things up, right? So the only reason this guy isn't making testosterone is because there's no LH to upregulate Leydig cell testosterone formation. And one of the reasons that was happening is because there's no anterior pituitary. That's it. Nothing insane, right? This is actually very common in third world countries where something might have happened and they got a pituitary tumor removed, but then there was never any follow-up, and the man ended up becoming infertile because he's just not making any sperm, right? And it's very unfortunate, and then oftentimes it's a very shameful thing to become infertile. So in these cultural places, they don't even end up getting that checked and getting it treated, even though it's a very simple fix. Just give them gonadotropins. That's it, FSH and LH. Also, GnRH and many other things in the reproductive and endocrine system have to be given in a pulsatile manner. GnRH is one of those things. It has to be released in a pulsatile manner, so you really don't give injections of GnRH. The only other acid trace that many people were compelled to pick was clomiphene. So let me just revise that medication. It's a very high yield medication. 722. Okay. So clomiphene. So you can see clomiphene is basically going to upregulate GnRH. And this does it in the correct manner. It's better than giving injections of GnRH. However, the patient didn't have an anterior pituitary, so it would be useless, right? Clomiphene is a very high yield medication. So are goserelin and leuprolide, very high yield medication. So you want to make sure you know how these things work, right? These all come up, especially in questions regarding endometriosis, regarding any PCOS. Those are all medications that are very clutch for patients with those conditions. This one, 30-year-old, okay, this was just a memorization question. 30-year-old man develops tingling around the lips and mouth after consuming a small portion of fugu, which is pufferfish in the Japanese restaurant. The liver of this fish contains tetrodotoxin, a substance that causes cardiac arrest when consumed in high doses. This patient's symptoms are most likely due to the blocking action of tetrodotoxin on which of the following ion channels. Now, if you block any of these ion channels besides chloride ion channels, you can have some level of cardiac arrest. So if anything, if you don't remember this at all, you would cancel out B. That's for sure. And then the tingling sensations that this patient is having should make you think that this is somewhat relevant to sodium or potassium, and you would pick one of those. Now, if you've studied this, if you recall this from pharmacology, right, then you would be okay, right? Because there's the HTC, histamine, total block of sodium, and then causing depolarization by opening sodium, right? You have to memorize this in whatever way you can, but regardless, the only thing that's actually relevant is sodium, not potassium, not chloride, not calcium. So you pick the sodium as choice and you move on. The only thing is between tetrodo and sigwa, you have to remember which one opens and which one closes. Tetrodotoxin actually binds the sodium channels and prevents depolarization. C causes depolarization by opening the sodium channels. Okay, so you want to make sure you have that little bit of revision for this topic just in case it pops up. It's a giveaway question only if you remember the topic. If you don't remember the topic, then it's like you're guessing and you're not going to be very confident, right? But these guys, you're supposed to master the first time you look at this and never really need to revisit this again, except maybe if you get a question on it, right? So that's why I always say, if you do a question on anything in New World, you should come back and look at the page where it's talked about, because you would get to revise it one more time, right? And the more times you revise these things, the better it gets. This is an interesting question. A lot of people got caught off guard. So a group of physicians submits a report to a medical journal that describes 3 patients with idiopathic pulmonary fibrosis who developed hepatotoxicity following treatment with a recently approved drug. In the report, the physician states that they are unaware of any previous description of this adverse effect. Which of the following best describes the study design used by these clinicians? Right? So they said in the question, the wording of the question is very critical. The wording of the question says that this is a study design being used by these clinicians. So in the end, you should come down to only 2 answer choices. Either this is a case series or this is a clinical trial. This is not a case control study because you don't have a control, right? This is not a correlational study because this is not an observational study, right? This is not a cohort study either because, again, this is not an observational study. Everything in first aid, those are all observational studies. And observational studies are different. So let's take where is it, right here? Yeah. Right, these are all observational studies. Case control, cross-sectional, cohort, crossover, adoption, twin concordance. Observational studies are different kinds of things, and they usually have 2 groups, and they compare things, and that's not what's happening in our presentation. Our presentation is about case series, okay? NBME 20 also had a question about case series, and I put the question in the PDF also. Right? Case series studies are studies where demographic information like age, gender, ethnicity, and information on the diagnosis, treatment, and response to the treatment are followed over a period of time. This is not an observational study. It's actually a medical research type of study. And that's what this study design that the clinicians are using is called. Down here is another question from NBME 20 where the answer was actually case series also. Okay, so clearly NBME likes some of these answers. NBME also loves every other answer they have in their answer choices, so another test might actually be the clinical trial answer choice. Why do some people think this was C? Well, physicians do report new side effects of medications in phase 4 of clinical trials, which is when the drug is under post-marketing surveillance. Patients take the drug because it is approved, but if any unprecedented side effects show up, physicians must report it to the pharma company through IRB, right? Internal Review Board. And this is stuff that I do as part of a clinical research coordinator. Right? So we mainly manage phase 3 and phase 4 clinical trials. Patients come in, they're taking their medication. If they ever have a side effect or if they ever get hospitalized for something, we get notified and then we file the review board data. We let them know what happened. We give them all the patient information, so on and so on. And we have to kind of black out the patient's private HIPAA information because the pharma companies don't need to know the HIPAA stuff. So they don't get the name, the date of birth, all of that, but they do get the diagnosis and the treatment and everything else that the patient was taking, etc. Drugs in phase 4 are offered often in clinical trials where the patient will consent to being randomized. Okay, in our question, they didn't mention anything about anyone being randomized or anything like that, nor is there a control to compare with. Right? Phase 4 clinical trials often happen with patients who might be given the correct drug or might be given some kind of placebo or might be given the current standard of care, whatever it is. The current standard of care thing is usually phase 3, comparing whether the current standard is good or the new thing is better than the current standard. This was not a clinical trial. right? This is not a clinical trial. This is actually a case series where the patient would only know everything about the patient, demographic, age, and all of that. So they can use all that. Of course, they know the diagnosis, they know the treatment. They can use all of that to actually formulate a case. Okay, this is just a series of cases. That's how I like to look at it. It's 3 different patients coming from a group of physicians. So different places where this happened. And this is probably some kind of rare side effect that they're all discovering, and now it'll get implemented into the medication's list of side effects. NBME 20 had this question: an investigator is conducting a study to identify potential risk factors for post-transplant hypertension. The investigator selects post-transplant patients with hypertension and gathers detailed information regarding their age, gender, and preoperative blood pressure readings, as well as current medications. The results of these studies revealed that some of the patients had been treated with cyclosporin. The study is best described as which of the following. This is clearly a case series also. You gathered a series of cases. Right? There's no control. If there's no control, it's not an observational study, it's not a clinical trial. You need to have a control for it to be an observational study or a clinical trial. Otherwise, how are you going to gauge whether there was any difference or anything to compare at all? And so that's always a good way to look at it. 38. A man accidentally touches the surface of a hot stove. 20 minutes later, a blister develops at the site. We've all been there. Light and electron microscopy of the inflamed tissue at this time is most likely to show which of the following. Well, first of all, no one cares. This is not something anyone would really know, and not anything anyone would do. But looking at the answer choices, a blister doesn't really have much to do with macrophages. A blister doesn't really have hyalinization of dermal collagen. No. C was correct. A blister definitely does not have necrosis of arterioles. It's not that bad. And blisters do not have eosinophilia. So at that point, you would pick C, interendothelial gaps in the venules. And the reason those gaps would be significant is because that's what causes the blister formation. You would need some kind of gap for things to leak. Okay, so the way you might have heard of this was the post-venial capillary dilation. Right? If this is just an inflammatory thing. Post-venial is related to this. And that's it. Always pick the least far-fetched answer choice that might be relevant to the question that's being asked. Didn't really like the image too much, but it did do the job. The question itself was good enough to understand what the correct answer is. 43-year-old woman comes to the physician because of a non-productive cough for 3 weeks. She has had 15-pound weight loss during the past 3 months. Chest x-ray shows 0.3 to 1 centimeter nodules in the right lung. A cytologic examination of fine needle aspirate from the largest nodule strongly suggests a malignant neoplasm. A photograph representative of the findings in this patient's lungs is shown, and they give you this, and you can see there's a nodule here and another big nodule here. Which of the following is the most likely diagnosis? Okay, so one answer choice you can definitely cancel out immediately is answer choice D, a hamartoma. So I've talked about this, I think, in the same explanation right here, maybe in block 1. This question up here, this is a Euro question where the answer was a hamartoma. And hamartoma would usually have cartilage tissue because hamartomas have local tissue in it. And this is a very benign finding that's usually found incidentally. Right? Benign finding. Our patient has something very malignant. Okay. On top of that, the fact that it's multiple nodules is always supposed to tell you that this is metastatic cancer. Right? And this is pretty much true in any part of the body. As long as cancer is happening from that bone, brain, whatever organ in itself, it'll be in that one area. Right? But if you have multiple zones of cancer, it's because that cancer came from somewhere else. Okay? And that's pretty intuitive. It's not so hard to grab that. On top of that, even more importantly, first aid tells you in the lung, metastases is actually more common than primary neoplasms, and it's usually going to be multiple lesions. Okay, most often from breast, colon, prostate, and bladder cancer. And for our patient, it could be that she maybe has breast cancer or colon cancer. It could be anything like that. Most likely breast, considering her age. Colon cancer would be maybe after 50. Bladder cancer, I don't see any reason for her to have. It could be that too, though. Maybe she smokes heavily. Either way, there was no reason to pick anything else. Small cell carcinoma is very central. It wouldn't be multiple lesions. Malignant mesothelioma would have encasing around the lung, and we don't see any encasing around the lung. Nor do they mention her working in any environment where she'd be exposed to asbestos. carcinoid tumor would have other symptoms of the carcinoid aspect. Okay, so I listed all that out here. None of that was true. Just the fact that she has multiple nodules was enough to understand this is metastatic lung cancer. This was again a very good question to gauge your understanding of the confidence interval. So a cohort study is done to evaluate the association between use of video display terminals by women and the risk for congenital heart disease in their offspring. The relative risk of congenital heart disease in newborns born to women who work for 6 or more hours using a VDT, a video display terminal, is 1.1, with a 95% confidence interval ranging from 0.8 to 1.4. Compared with women who are not exposed to VDTs, which of the following is the p-value calculated from a chi-square test? As a researcher, as a biostatistician, as a statistics person, you know that this stuff is just bad data. Why? So what you're supposed to do for mastering this is, first of all, remember cohort, you should only spell cohort with 2 R's, right? 2 R's. Cohort is only spelled with 2 R's. Why is that? What are these 2 R's indicative of? The 2 R's are indicative of relative risk. So if the question didn't tell you that the way you would evaluate the data is using relative risk, you need to be able to figure that out. Okay, the question didn't need to tell you that they did a relative risk, right? And they were really nice to tell you that. They did the relative risk. They could have just told you that after looking at the data, the 95% confidence interval was 0.8 to 1.4. And you should know that this is due to relative risk because they told you it's a cohort study. Okay, great, that's done. So you figured out it's relative risk because I'm imagining they didn't tell you that. Relative risk is division, right? Relative. Division, usually the biggest thing as a mathematic person in division is 2 things. There's 0 and 1. You can never divide by 0, so forget the 0 stuff. And when you do division, and anytime you divide 2 numbers and you get 1, that means you divided 2 things that are equally the same, right? If you do anything x divided by x, that means both things are the same. Any 2 numbers you divide, they have to be the same number, otherwise you would not get 1. And if you divide 2 numbers and you get 1, that means there's no difference. No difference means that this data is bad, right? There's no data, there's no difference between what you're looking for and what could have happened, so you don't get rid of the null hypothesis. And that's what happened in this data. You can see that the range from 0.8 to 1.4 has 1 in it. So that means that this data that they looked at, where people with VDTs and then women without VDTs, trying to compare that, there's no difference. So that means that our p-value should not be less than 0.05, right? Because when your p-value is less than 0.05, that's a great thing. That's a sign that whatever data you collected did not occur purely due to a chance, okay? So you have to pick the other answer choice where the p-value is more than 0.05, and the only time that is happening is D, okay? E does not make sense. You can't have a probability of more than 100%. We all like to say, there's a 200% chance of something happening. Okay, sure, but probability-wise, it's either 100% chance it'll happen or less than 100%. That's it, okay? So there's no such thing as this answer choice. This was just a trick answer choice, right? So you were really just between these 2. That's it. Yeah, nothing else. Okay, so it was just going to be D. Very good question. Very informative question. A lot to discuss here. If you're not confident with this stuff, then you want to make sure you get to that point. You want to get confident with it because it's pretty easy. Right now, what's the other thing? There's one more thing you need to know. So let's just go back and take a quick look at it. Not 262. I must have written the wrong thing. Where's the talk about it right here? 274, 262. Oh, I wrote it backwards. Okay. Fit width. All right. So there's one more thing to look at in the confidence interval discussion, which is the 95% confidence interval for a mean difference. And with differences, the only major thing in difference where you would have no difference is when you subtract 2 numbers, x and x, that are the same thing. And what do you get? You get 0. Any 2 numbers that you subtract when you get the same number, where they're the same number, that's the only time you get 0. So if you subtract 2 numbers from each other and you get 0, there's no difference, which is the same thing that we're talking about here, right? If there's no difference between the 2 things you're comparing, then you don't reject the null hypothesis. So for mean difference, when you do a confidence interval for a mean difference, and they'll tell you that in the question, you want to make sure that the range of numbers they gave you doesn't include 0. So for example, it might say that the range of numbers for their confidence, 95% confidence interval, they might say that the range goes from like negative 0.3 to 0.5, right? So clearly this includes 0. Okay, and when that happens, that means that there's no difference, you don't reject the null hypothesis, and your data was just very insignificant. Okay, so all the money you put into that research just went to waste. Not so hard to remember, right? Not so hard to remember. So odds ratio, the odds of things is division. The only way you can divide two things and not have a difference is if they're the same number, and that would give you 1. So if you see a 1 in your 95 confidence interval for odds ratio or relative risk, right? Relative is also division. You would get that data is insignificant. For mean difference, difference is subtracting. Subtracting things can give you a 0. If they're the same, there's no difference between them, and then you reject it there too. The data is all rejected. The data is useless, insignificant data. The null hypothesis is not rejected because the null hypothesis says there's no difference. Right? Null hypothesis says hypothesis of no difference. So you keep that. The only time you'd reject the null hypothesis is when there is a difference, and that's your alternative hypothesis. Right? So this is stuff you're supposed to get very confident in talking about. There should never be any confusion in discussing any of this. These are giveaway questions, very simple stuff. It's just a little bit about statistics. It could come off annoying to you depending on how much you like math and how much you like statistical stuff, but it's not really up to what you like. Whether or not you like it, it's still going to be on your test, so make sure you understand it the best you can. This was a really good question too. Drug X is given to a 25-year-old normal subject, so he's healthy. Drug causes resting heart rate to increase from 62 to 74. Prior to administration of the drug, the subject's heart rate increased to 150 with exercise. After administration of drug X, his heart rate increased to 98 per minute at the same level of exercise. The mechanism of action of drug X most likely involves which of the following? Right? So this concept plays a bigger role when it comes to opioid receptor agonists, because this is a discussion about full versus partial agonists, as you can see from the answer choices. So you can definitely knock out answer choice A. This is not an antagonist at dopamine receptors. It has nothing to do with heart rate directly. Then you talk about full agonists at angiotensin 2. That's also pretty irrelevant because this isn't a question about blood pressure per se either. It's really talking about just heart rate, which is a beta 1 receptor, right? So full agonist at ADH, again, doesn't make sense because we're talking about heart rate. Heart rate is beta 1 because you have one heart. Then the only answer choices you were really left were, I don't know why I keep doing this. Left were between D or E, and this is D, right? This is just going to be partial agonist at beta adrenergic receptors. So why is that correct? Why the partial agonist part? So partial agonists have weak agonist activity on their own, right? So thus, in this case, it causes the heart rate to increase, and that's a beta adrenergic effect. But when an actual agonist is present, aka when you are exercising, you're producing norepinephrine and epinephrine that have full beta agonist effects, the partial agonists actually have a mild antagonist effect, and the heart rate decreases, right? And that's what they're showing you in the question. That's what they're telling you in the question, because they have the exercise part. See? So after exercise, right, subject's heart rate prior to the administration of the drug, the subject's heart rate increased to 150 per minute with exercise. So he was exercising and the heart rate went to maximum 150. Then they gave him drug X and the heart rate came down to 98, right? Which is pretty logical because it would not go more than 150. He was exercising and it was already at the maximum as it could be. Partial agonists in the presence of a full agonist will cause an opposite effect, and that's the moral of the story here, right? And this is why you can use partial agonists at opioid receptors to help patients who have opioid problems, right? Opioid addiction, because a full opioid will cause opioid symptoms. When you give somebody a partial opioid, it causes the opposite symptoms. And you can use partial agonists at opioid receptors to wean people off of their addiction to opioids. Okay, so very important to understand that concept. It's a very realistic thing that is clinically relevant. You're going to be using this concept in your practice. This was a dumb question. Like, there's absolutely no reason for you to know this. Which of the following terms best describes the fibrous proteins that form the two-dimensional network on the inner surface of the nuclear membrane. Right? So first of all, what the hell is a two-dimensional network? Second of all, why? Right? There's no reason for this to be a question. UWorld has asked questions about fibronectin, and that's probably the most respectable that you can get, like this, or the least respectable you can get. Any lower than that would be this, right? To leave it to NBME to ask a question that's lower than the least respectable question. You shouldn't even need to know what fibronectin is, right? Or integrins, all of these. These are very molecular, tiny things that are completely irrelevant. But again, UWorld did make you learn about it, right? So integrin and fibronectin help connect the collagen to this actin mesh on the other side, right? So this is how you kind of latch onto things. Right? Very nice diagram here. You can see fibronectin and actin filaments are answer choices here. This image tells you why they're wrong answer choices, because it's not relevant to the nuclear membrane. Okay? Then, because this is the plasma membrane. So this image here I found online is related to the nuclear membrane. So you have your nucleus here. Okay, you can see a bunch of things here that could be answer choices in future exams, like the emerin over here. Right? This is the laminin. Sorry, I keep saying laminin. The lamin, right? This is the lamin. Laminin is a different thing. Laminin is actually just like fibronectin, and it's in the book. So this is from the book. You can see fibronectin, laminin, integrin, right? Part of the hemidesmosome connection at the basal membrane. These are all using plasma membranes. Everything here is using plasma membranes. Our question is about the nuclear membrane, and the only thing here that was related to nuclear membrane was the lamin. I couldn't even find the granum. I don't know what that is. But the lamin, this one right here, is related to the nuclear membrane. Okay, and I described it more right here, but this is again something you don't need to remember. Unless you're about to take more NBMEs, you don't need to remember. This is not going to be on your step 1, but it could be on another NBME in the future. And you can also have another NBME where the next correct answer might actually be this emerin thing. Right? I don't really see anything else here that you might not catch, but lamins are all over here. There's a bunch of lamins in here, and then the only other thing is the emerin. Okay, so really stupid. I don't even know why they invest time trying to find this dumb stuff, but that's what this question is about, and I'm sure a lot of people got it wrong. I'm really sorry about the silly mistakes where I had the wrong answer written here. Doing this while fasting or even after opening fast has been really demanding, but it's a good thing we get to go over it together right here so I can fix it up, and it's not so bad. Number 43 here, a 7-year-old girl is brought to the emergency department because of a 1-hour history of excessive sleepiness and slurring of speech. So that sounds kind of weird. The mother reports that the girl seemed to be feeling well earlier in the day and had eaten lunch 2 hours before this episode. So in America, if someone comes to me, right, a mother comes to me with her 7-year-old daughter looking like this, I'm gonna immediately think something's wrong, because this doesn't happen. This doesn't happen. If you were born in America and everything's being taken care of and you're regularly seeing a doctor and you're going to school and you're doing all this, something like this would not happen to a patient. It's just really rare. Fingerstick blood glucose concentration ordered on arrival shows that it's just 42, which is low. IV dextrose is administered and 5 minutes later her symptoms resolve. But is she starving? Is she homeless? Is there no food to eat? Like, what's the problem? Why is her sugar so low? The patient has a history of 3 previous ED visits for similar symptoms during the past year, which is a red flag. That's the red flag that you immediately go ahead and figure out, okay, what's happening here. Her pulse is 94 per minute, respirations at 24, blood pressure is a little lower. Physical exam shows nothing wrong. Results of serum studies obtained because you think something is wrong. You ordered these serum studies before administering the dextrose, and you see that the C-peptide is very low, but insulin is very high, and beta-hydroxybutyrate is normal. So she's making ketone bodies because she's constantly hypoglycemic, and it's due to exogenous insulin. She's being given exogenous insulin. If she was making the insulin herself, maybe because of an insulinoma or something, then the C-peptide level would also be correlating and it would also be high. Okay, so this mom must be giving the baby repeated bouts of high levels of insulin to practically commit child abuse. This is Munchausen by proxy, and you have to report this. Okay, so that's A, factitious disorder imposed on another. No reason to pick anything else. Really clear question, not bad at all. This was a good question to teach you a lot of stuff too. Oh, I forgot to finish this, so I'll finish this with you guys right here. 55-year-old man comes to a physician because of a 2-week history of palpitation and anxiety. He has a primary hypothyroidism treated with levothyroxine. Okay, that's pretty common. Says that he has been taking twice the prescribed dosage of his medication for the past 2 months. Believe it or not, that's also pretty common. His pulse is 104 per minute, blood pressure is very high. Physical exam shows a fine resting tremor because of the excess levothyroxine. Which of the following sets of lab findings is most likely in this patient? So levothyroxine is T4, okay? So if you're taking a lot of levothyroxine, your T4 has to be high. So that cancels out choices D, E, and F, right? That cancels out D, E, and F. Serum triiodothyronine would also be high because T3 is the active form of thyroxine, and clearly he has symptoms of active thyroxine. So that just cuts it all down to A, and you just pick it. Thyroid iodine uptake, the thyroid gland iodine uptake would be very low because you're not trying to take up more iodine, because you're not trying to make more thyroid hormone, right? This patient's TSH levels will be very low because there's going to be that feedback telling them to stop making TSH. Why would you have confusion here? I'm not sure, but just make sure you understand what the concept is and get it. So some people thought that T4 would obviously be high, but T3 would be low because something would magically stop the conversion of T4 to T3. And that kind of feedback doesn't exist. If you have a lot of T4 in you, it will peripherally be converted by 5' deiodinase into T3. There's no feedback mechanism that stops 5' deiodinase activity. All right, so that's let me just show you page 383. So right here we have our thyroid medications, right? So that's the discussion on levothyroxine down here. Levothyroxine, which is T4. The other guy, liothyronine, this works in that manner. So liothyronine doesn't need conversion. That's actually active T3 that you're taking in. So that means that if this patient, instead of levothyroxine, was overdosing on liothyronine, then the T3 would be very high, but T4 would be low because you make T4, but you're eating T3, so you're going to stop making T4 because, of course, the thyroid has a negative feedback to the thyroid gland, so the hormone will stop being produced. So you would stop making T4, but your T3 would be very high because you're eating it, and you would stop doing thyroid iodine uptake, right? So answer choice E would be the one for liothyronine. Liothyronine is T3, so when you ingest a lot of T3, you stop making more T4, thus you also stop taking up iodine. Choice E. Okay, and that would be the correct answer if the question was changed. It should just say, instead of levothyroxine, it's liothyronine, right? And that's totally something I can imagine happening on the next NBME or something. 45. This was also really nice. So a 55-year-old man with alcoholism is brought to the emergency department 30 minutes after consuming a bottle of methanol. In order to decrease methanol toxicity in this patient, the physician recommends to give him even more shit and give him ethanol. To increase the km of hepatic alcohol dehydrogenase from methanol in this patient, the ethanol must act as which of the following? Okay, so now, through sheer logic, if we're trying to stop methanol from being digested, the ethanol must be competing, so you would just pick competitive inhibitor and move on, even if you haven't mastered Km and Vmax. But you can see why NBME, as shitty as they might be, is a great way to gauge how ready you are for step 1, because this question tests you on your pharmacological understanding of Km and Vmax. Okay, so you need to remember the mnemonics and stuff that I have in my book. Let me just show that real quick. 242, and I put it in the explanation there too. So Km is equal to the substrate concentration at half of Vmax. That's one concept that's very important. But this stuff here is the most useful, right? So they said that they want to increase the Km. So Km increases when there's competitive inhibition. All right, that's going to cause a lower potency, and there will be no change to Vmax. Vmax will not be affected. Non-competitive inhibition has no Km changes, and your Vmax will decrease. The speed at which the whole process is happening would decrease because you have an inhibitor that's stopping everything without competing. It's using a different part of the enzyme, right? An allosteric site, stuff like that. So Km increases competitive inhibitors, and this is an equal sign, so it's true in both ways, and that's all this question was about. A very solvable question. This is the point of your studying. When you're studying, you're supposed to take concepts, learn them, understand them, and then simplify them in the best way you can. And that's what my PDF does for pretty much every topic. And that's why it's been such a successful PDF that's been selling very well. Right? So very important to make sure you understand that. And then of course, when you study something on a given day, you go do questions, and when you do questions, you learn how to apply it. Right? Not bad at all. Down here, I also wrote another thing. This is something I talked about in the video where I talked about KM, I think in my 2018 video. So think of KM as Kim Kardashian and the relationship dramas. To increase Kim Kardashian levels of the scenario, you just introduce new competition of hot women, and the enzyme, which is the one running everything, will now be attracted to the new hot woman. Right? So that's something that really helps understand how KM works if you're trying to use something different, maybe. But the point of this statement is to understand that you need to come up with silly things like this to really grasp things that you might not be confident with. You might have studied KM and Vmax maybe 5 to 10 times already, and you're still getting questions wrong about KM and Vmax. It's time to change something up. Get it simplified. Okay? This scenario of using ethanol to battle methanol is actually a real thing. And it happens if you don't have fomepizole, right? So there's medications, but if you don't have it, or if you're in a rural setting where something is running out, you can do these things to kind of help with the toxicity aspect, right? 46. I wrote never get these questions wrong, so really don't. There's never any reason to. I got significantly better at this after having first-hand experience in my job as a clinical research coordinator, where we handle researches that are in either phase 2, phase 3, or phase 4 of trials. There's a different team for the phase 1 team. They do their own thing, with phase 1 being up to 10 people. So these phases I've talked about a lot, right? I've talked about it a lot in my videos where they pop up. So on this page you can see the way to remember how many people are involved for each one of these is just raise it 10 to that power. So 10 to the 1 is 10, and that's your small number of people. 10 squared is 100. So here you could have 100, 200, maybe 500 people. Phase 3 is 10 to the 3rd, which is 1,000 people. So that's your entire hospital. Right? And the phase 4 is the world, 10,000. Right? That's everyone. Everyone around the world is taking this medication. SWIM is the way to remember safety. Does it work? Which is efficacy. Right? Is it effective? I for improving. Right? Is it better than what you already had for treatment of the same exact thing? And then finally, marketing. Right? So you see post-market surveillance. Very easy to remember all of that. So what happens in this question? 21-year-old woman with asthma comes to the physician because her current medication regimen is not relieving her symptoms. The physician tells the patient about a clinical trial of a new drug for asthma. This trial is a large, randomized, prospective, double-blind study on volunteers with asthma. Okay, this trial is most likely occurring at which of the following phases of drug development? So look, you just had a patient, right, who might suit it's called the criteria, what criteria was it called? I forgot what the first word I'm thinking of, but it's you need to match all the criteria to be able to take the medication. So when pharmaceutical companies give you these medications, these are free medications. Your pharmacy, you don't have to pay for it, your insurance doesn't have to pay for it, it's free. The pharmaceutical company is paying for it. But those medications are made with criteria that you can only take this medication if you match all of these criteria. And sometimes criteria could be something like, what have you used for your asthma before? If you used drug X, Y, and Z for your asthma before, you can't take my drug, right? Because your data is going to be irrelevant to me. That's a confounding factor, etc., etc. What's happening here is this is a phase 3 trial. This is exactly how a phase 3 trial would be. We're now going to be evaluating the difference between what this patient has taken and what this drug does. Right? She's been taking a current medication regimen and it's not working. What she's taking currently is probably the golden standard of treatment. So this medication might actually have a criteria. What it says, you must have tried something else already. It didn't work. Now you're going to take my drug, and then we're going to see if my drug from my company did a better job than what you were taking before. That's the eye of improvement from SWIM. That's phase 3. Okay? Very straightforward. Nothing crazy here, but you have to make sure you understand it to be able to see it in that manner, right? Not that bad at all. What is phase 0? So some people asked about that. So phase 0 trials are also known as human microdosing studies that are designed to speed up the development of promising drugs or imaging agents by establishing very early whether the drug or agent behaves in human subjects as what was expected from preclinical studies. And this was actually relevant for us right now because with coronavirus going on, we're trying to speed up everything. So every time a drug or vaccine is discovered that might have even a bit of a chance of working against coronavirus, it's put into phase 0 trials, which jump straight into phase 3 trials or phase 2 trials, because you're just trying to see, is it even doing what we're hoping it'll do? You know, if it's not going to go in the direction that you're hoping it'll go, you drop that immediately and you start doing something different. Okay, so phase 0 trials are a thing. It's just very, very uncommon. There's almost never a reason to speed up the development of a promising drug. But right now in a pandemic, there is a reason to speed up the development of a promising drug or vaccine. So, you know, as irrelevant phase 0 might have been, I can pretty much see in 2021, maybe even 2022, phase 0 being one of the things here. Okay, so let me, I forgot to put it into my book too. I just want to add that in real quick. I'll fix that later. Okay. 47, again, another great question to test you on your mastery of the personality clusters. Okay, I've taught them in a very nice manner in my videos. I'll go over it right now too. I associated them with certain characters to help make things easier. So let's look at the question and then we'll look at my book. 27-year-old man who works from home as a software engineer comes to the physician with his girlfriend because she is worried that he may be depressed. His girlfriend tells the physician, I practically have to drag him out of the house to see my family or friends. And then when we get there, he refuses to talk to them or interact with them. He just stands around looking uncomfortable, and then he asks to go home half an hour after we arrive. She says that he seems fine when he's alone with her or with his own family and friends. After she leaves the room, he tells the physician, I wish I could have relationships with her family and friends, but I can't. I just know they'll hate me once they get to know me. He has been this way for as long as he can remember. This patient most likely has which of the following types of personality disorders? And then they put antisocial as answer choice A, and you're going to be like, yeah, he's so antisocial, he doesn't want to socialize, and you'll pick it, and you'll get it wrong. So let's go back and take a look at the clusters. So for my book, first I fixed the errata, right, because in 2019 they forgot to write, you know, they did accusatory, aloof, and awkward, but they only put the two things, aloof and awkward. The accusatory is your paranoid person. That's also a cluster A personality. They fixed this in First Aid 2020, so make sure you remember that. Paranoid is a cluster A personality disorder. So cluster A is this guy, the Tin Woodman from The Wizard of Oz, right? This guy is very paranoid, right? Because of the experiences he had gone through. If you don't know the story of The Wizard of Oz, first of all, you're missing out on life. Second of all, you should go watch it and learn it. So, you know, go ahead and invest a little time in watching that and give yourself a little break. He's very paranoid because of what he's been through in life. He's very schizoid because he is actually okay with social withdrawal and isolation. He would be just fine being alone. No problem whatsoever. Doesn't even want to be associated with other people. And he's very schizotypal because clearly he has a very eccentric appearance. He's a guy with this on his head, right, and all this metal. Perfect fit. Cluster B, I put Cardi B. Now, almost everyone here should know about Cardi B. She would fit the different scenarios over here very well because although these things might not be directly true about her today, at some point she's fit all of them in some way. So she is antisocial. What is antisocial? You know, in common talk, in non-medical talk, everyone uses antisocial to describe people just like the person in our question. But antisocial people are actually really mean. This is a person with disregard to the rights of others, very criminal, very impulsive, very hostile, and very manipulative. Okay? Borderline is one person saying that, you know, everyone is, the main thing here is splitting. So you want to make sure you remember splitting as the defense mechanism they always use. So either everyone is great or everyone's bad. That's it. Right? You can see how there's another list of impulsivity, right? Emotional emptiness, suicidality. There's a bunch of mood issues here. Histrionic, again, very attention-seeking, shallow, right? Sexually provocative. Reasons I could pick Cardi B to describe this, right? Narcissistic, grandiosity, sense of entitlement, lacks empathy, often demands the best, and reacts to criticism with rage or defensiveness in a very illiterate manner. right? So that's why I put Cardi B as the cluster description for that. For cluster C, I chose Sheldon Cooper from The Big Bang Theory. Our guy is just like Sheldon Cooper is in that show. So if you've never watched Big Bang Theory, that's a very long show with many, many seasons. You can't really watch all of it now, but you can definitely go back and watch clips here and there. Sheldon Cooper is actually all three of these things. He is avoidant, he is obsessive compulsive, and he's dependent. Our patient in that question is avoidant. Okay, he is socially inhibited, timid, hypersensitive to rejection and criticism, which is why he said that if his wife's family got to know him, they would all hate him. Right, that was him making that up. And the main key thing to separate this from schizoid is that he desires relationships with others, and he said he wishes he could get to be closer with her family because he is close with his own family. So he's not schizoid, right? He's not schizoid. And he's not antisocial because he's not criminal, he's not impulsive, right? Sheldon Cooper acts the same exact way actually in an episode where something similar happens. He gets married and his wife takes him to her family's place, and he doesn't really want to meet any of them, doesn't want to talk to any of them, feels weird. God forbid you ever tell Sheldon Cooper something where he's wrong or something. This is probably exactly how he'll look at you, because he'll be very offended and hurt. Okay, he is dependent. He has an excessive need for support. In the show, he's a physicist. He comes up with amazing ideas and stuff, and when he shares them with his friends, they have to applaud him. They cannot criticize it. They have to applaud him. They have to tell him he's so smart, blah, 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 right? And obsessive. He's always organized. Everything is perfectly organized, and he has a very consistent way of acting in the sense that he believes everything he thinks he's doing is perfect and is the only way to do it, right? That's your egocentric behavior. There's no other way to do it besides the way he does it. Okay, it's a great way to make sure you can organize these clusters and then get everything in a way that when you see a question, you can immediately first associate it to a cluster and then pick something from that cluster. Right? It's a perfect revision. Nothing bad. 48 was a very easy question, even if you're scared when you see questions about breast cancer. 38-year-old woman comes to a physician because of blood-tinged discharge from her right breast for 3 months. Menses are normal. She takes no medications. There's no family history of breast cancer. Physical exam shows no breast mass, no palpable axillary adenopathy. Right, so it's not a glandular cancer. She doesn't have any fibrous cancer. Right, that's what these things mean. Fibrous cancers will make breast masses. Any mass with the glandular stuff would be axillary adenopathy because it would have metastasis and stuff. Bloody discharge can be expressed from the upper outer corner of the right nipple. Mammogram shows nothing. Okay, which of the following is the most likely cause of discharge? And it had to be nothing but C, intraductal papilloma. Even if you didn't know what the rest of these are, it's not a prolactinoma though. You should probably be at least able to cancel out prolactinoma. Paget disease of the breast is pretty weird looking because of the eczematous. There's like an eczema type skin that it forms around the areola. It looks really weird. They didn't talk about that on the physical exam. No breast changes, no nothing. Fibrosarcoma or fibrocystic would both have masses. Any fibro something has masses. Okay, so not so bad. This question in itself was great. If you struggled with it, again, revise, right? That's what you're doing every time you do an NBME. As you can see, NBME, this NBME and almost any NBME hits every part of first aid, leaving out only a few things. It doesn't talk about any of the graphs in cardiovascular, right? And it doesn't talk about any of the graphs in respiratory. It leaves out some of those few things that are physiological. But other than that, it hits every system and every disease you could really think of. 49 kind of sucked because this x-ray was a piss off, but the question was very clear and it was still pretty doable. An 18-year-old woman is brought to the physician because of a sharp chest pain and shortness of breath 1 hour after receiving a non-penetrating injury during a rugby game. Her respirations are 22 per minute. Physical exam shows decreased breath sounds and increased tympany to percussion on the right. So this lung here, right? This lung here, first of all, this is a pretty big looking lung, right? But other than that, the heart is looking fine. The heart is looking just fine. So that's not too bad. This lung here, though, it's really big and black. It's so clear that I can see the ribs behind it almost perfectly. Whereas on the left lung, you can see there's some kind of, other parts from the bronchi and all that. The right lung is perfectly clear. That means it's just air. It's just air. There's only no lung, just like this one. So whatever's happening in this lung here is what's happening in that lung in the patient. Okay, that's a pneumothorax. You look at your answer choices, right, and you would pick. Oh, they didn't even put right. Okay, they wanted to know what would occur. So first you needed to figure out it's a pneumothorax. Then you learned something about a pneumothorax. But I was talking about the tympany. So tympany and all of this stuff would happen because it's only air. When it's just air, you're going to have decreased breath sounds because there's no lung. And tympany, because air, voice sounds, air carries sound very well, right? So tympany is going to be increased. This patient is at greatest risk for developing what? So obviously definitely not amyloidosis. This has nothing to do with developing carcinoid tumor. Diffuse alveolar damage, okay, maybe. Empyema, no, that's going to be related to infection. Pulmonary edema, no. First of all, you need a lung to have pulmonary edema, so that lung is gone. Okay, pulmonary embolism, again, you need a lung to have the embolism, and that lung is gone. And then you have respiratory acidosis. So you're left between diffuse alveolar damage or respiratory acidosis, and you pick something. Now, diffuse alveolar damage would happen in alveoli that are functional. Right? And our patient doesn't necessarily have functional alveoli at the moment in that lung, on the right lung. So this patient was actually at most risk of getting respiratory acidosis. And I described it over here. But I really hated this x-ray though, right? And I wrote that. Because, like, who takes an x-ray like this? Why is the bone so goddamn bright? Why is the heart so bright? Why can't I see the esophagus and whether or not it actually shifted like it should? Right, because this is practically a tension pneumothorax, so the esophagus was shift to the left because the right lung actually collapsed, right? And then there was information right here. So honestly, none of the choices make sense once you look at everything, leaving only G to be remotely feasible. Arterial blood gas studies may show respiratory alkalosis caused by a decrease in CO2 as a result of the tachypnea, but later on, hypoxemia, hypercapnia, and acidosis would be seen. Would be seen. Okay, so that's just a little bit of physiology you might not have actually seen in another question before regarding pneumothorax. So in that aspect, this was a pretty creative, intelligent question, and I don't mind it. It wasn't so bad. At least the answer choices all just couldn't be possible. And then this is my favorite question ever. I love talking about this stuff. 15-year-old girl is brought to the physician because of a 3-day history of fever, sore throat, and malaise. Temperature is 102.6, high, so she has infection, she has fever. Physical exam shows diffuse pharyngeal erythema, moderately enlarged tonsils, tender anterior and posterior cervical lymphadenopathy. So if a young girl comes in with these symptoms, you immediately think of mono, right? Maybe she kissed a new boy or something. You immediately think of mono. Complete blood count shows you everything looks okay. Right? Leukocyte count is pretty high for obvious reasons. She's got infection. And then everything else looks okay, but then you have atypical lymphocytes. Incubation of this patient's serum with sheep erythrocyte results in agglutination. And they didn't even need to tell you that, but they're really confirming for you that this is mono, right? This is due to Epstein-Barr virus. The atypical lymphocytes in this patient are most likely what? And then this picture I put here to show you what they're talking about, okay? So these are both lymphocytes. Now, of course, on microscopy, you can't really tell by looking at a lymphocyte if it's a B or a T cell, all right? But just keep in mind, the atypical lymphocytes in Epstein-Barr virus infection are actually reactive T cells, So the atypical lymphocyte is this guy over here, because he doesn't look like a typical lymphocyte, which is one on the left. So the atypical lymphocyte in an Epstein-Barr virus infection is a reactive T cell that's trying to fight back the viral infection. The infected B cell, right? Epstein-Barr virus infects B cells. The infected B cell looks normal. Nothing would happen to it. It would look normal, okay? So, of course, they put B lymphocytes as answer choice A because you're going to think of Epstein-Barr virus. You're going to be so excited. You recognize mono. You recognize the EBV confirmation test. You pick B cells because Epstein-Barr virus affects B cells. And you'd be wrong, right? So that's why this is my favorite question. I love asshole questions that are clear and they make you feel so good about the answer that you pick it and you're wrong about it. Somehow that brings me some kind of weird guilty pleasure. And it's a great way to learn, though. It's a great way to learn. It's very funny. You never forget it again, right? So they also wanted to confuse you by putting CD4 and CD8 lymphocytes to test your immunology knowledge. CD4 are T helper cells. That's not what you're going to have to fight a viral infection. you would have cytotoxic MEC1 using CD8 positive T cells, right? That's as a choice C. Now, in comparison to this scenario, if you have an AIDS patient, and I put that down here, if you have an AIDS patient with primary central nervous system lymphoma, and they give you the same exact image, and they ask you what are the atypical cell types you're seeing, there, the atypical lymphocyte is actually the B cell. Okay, so a very important point to understand. There, it's actually a B cell. In a primary central nervous system lymphoma, they can give you the same exact image. The question scenario would change, of course. It would be maybe like a 60-year-old patient with HIV, doesn't take his drugs, blah, blah, blah. You know, no fever or anything. They do the CBC count, and then they see that there's lymphoma. It'll be very apparent to you. And then they'll give you this image, and they'll be like, what is that atypical lymphocyte? There you pick B cells. Okay, that is actually an infected B cell that has lymphoma, so it looks atypical. It's cancerous. Right here, the B cells would be normal. The T cell would be the reactive CD8 positive MHC1 using cytotoxic T cell. That's going to try to fight the viral infection. Right, so this is one of my favorite questions. I love this question. Every time I get a brand new Step 1 student that just started doing Step 1 and they say they finished micro, I ask them this. I have yet to find someone that got it right, so it's been pretty fun. Alright, so we're done with NBME 24. Thank you very much for joining. It was very hard. It was very long. The test was easy. Doing the explanation was very hard because of fasting and all that. Now, depending on how you did on the test itself, make sure you revise everything, get a good understanding of all the significant questions. So questions like this one are insignificant, so don't worry about this too much, okay? But stuff that actually tests you on the knowledge of whatever is significant. So like 41 over here, this was significant. Even though this is not a type of question you would really see on Step 1, it's good because it tests you on your understanding of partial versus full agonists. And this one over here about the confidence interval, all of these last 25 questions were really cool. They were good, they were to the point, they were well written, and they got the point across in helping you understand what's happening. Alright, so keep it up, guys. Soon enough I'll be starting CK videos, so stick around, probably after Eid. Until then, I'll keep making a couple more things relating to Step 1, and then I'll see you guys again very soon. Thanks a lot for joining. Good luck.